Hi everyone, Dr. Minas here. Today we'll discuss echocardiography. As you know, this is not a single discipline, but rather encompass multiple levels adapted to different specialties and patient populations. The well-known or most well-known modality is comprehensive echocardiography within cardiology, serving as the reference standard examination with precise measurements. Then there is point-of-care echocardiography, the tool of intensivists and anesthesiologists or ER physician, featuring focused examinations and rapid decision-making. Finally, we have advanced critical care echocardiography, provides more sophisticated hemodynamic monitoring. As illustrated in the table, these levels have distinct objectives and require investment different training investment. Even the duration of examination varies very significantly between levels. Also classified and as basic, advanced, and expert level. Today we focus on point-of-care echocardiography, which has transformed our practice in ICU and anesthesia. Which level of competency do we need? So we start by the basic level. I'll introduce you to the POCUS Pyramid, and we'll explore standard views and key pathologies in the upcoming videos. So this is a bedside examination. This involves targeted examination performed directly at the patient's location by clinicians who integrate finding into their diagnostic reasoning. This approach is essential because traditional physical examination has limitations, and our practice in anesthesia ICU or ER requires rapid and accurate assessment. The pyramid is structured model comprises four competency levels, each building up the previous. Imagine a pyramid where you cannot construct higher levels without solidifying the foundation. Level 1, technical foundation. Let's begin with the machine. Cardiac ultrasound utilizes 2 to 5 MHz frequencies, a compromise offering sufficient penetration while maintaining acceptable resolution. So artifacts are physical phenomena to understand. Bone creates acoustic shadows while air causes total ultrasound reflection. This explains why we work through intercostal cardiac windows. Next, nobology or machine setting. Depth adjust to visualize the anterior heart. Too superficial, you will miss the posterior structure. Too deep, you will lose details. Second, gain. Overgain creates noise. Undergain produces images that are too dark. Time gain compensation, TGC, balances depth brightness. Focus, place it at the structure of interest, example, mitral valve level to optimize resolution. Probe selection, cardiac probe or phased array probe with small footprint is essential. It fits the intercostal space. After mastering the machine, we progress to view acquisition. We had three main cardiac windows: parasternal, apical, or left parasternal, apical, and subcostal. These windows enable 5 standardized echocardiographic views. Parasternal long axis. Parasternal long axis visualize mitral valve positioned at the sternal border, third, fourth intercostal space. The parasternal short axis, multiple levels, but papillary level is crucial for ventricular function assessment. Apical four-chamber view, 4 chambers, ideal for right ventricle, left ventricle compilation, and septal evaluation. Apical five-chamber view adds the left ventricle outflow tract and the aortic valve. Finally, the subcostal view, essential in emergencies and challenging situations, showing heart and inferior vena cava. To obtain quality image, proper Probe manipulation is crucial for fundamental movement, sliding, tilting, rocking, and rotating. Ergonomics also are vital. Maintaining the ulnar border contact with the patient ensures excellent stability. Level 3 Anatomy recognition. Once we acquire images, we must recognize anatomy. Normal anatomy. Left ventricle is circular with thick walls. RV crescent-shaped with thin walls. LA left atrium posterior to the LV. Right atrium triangular shape. Valvular structures. Mitral valve between the LV and LA. Aortic valve centrally located. Tricuspid valve between the right ventricle and right atrium. Pulmonary valve anteriorly positioned. Spatial orientation is equally important. Anterior posterior, screen right left, heart base apex. This 2D, 3D correlation is fundamental. The probe marker corresponds to the screen marker, guiding image orientation. Then we should know key anatomy structures in each view. For example, parasternal long axis shows left ventricle, left atrium, aorta, and mitral valve. The fourth level or clinical application. Let's proceed to practical application. So critical pathology to recognize include LV function, normokinetic, hyperkinetic, global hyperkinesia, segmental akinesia, RV pathology, dysfunction, paradoxical septal motion, effusions, pericardial, pleural, significant valvulopathies. So we assemble these elements to define a pattern. For example, dysfunctional RV with paradoxical septal motion suggests PE. The key is not seeing isolated elements, but recognizing their significant combination. This integration creates diagnostic value. This pattern recognition represents the powerful aspect of POCUS ultrasound. The pyramid's final component comprise essential pillars. Hands-on practice, progressive learning require 30 to 50 examinations for level 1 and more than 100 for level 2, as shown in multiple studies, with mandatory initial supervision. Proper methodology enables rapid, effective learning through spaced repetition and deliberate practice. Talk about documentation. Various protocols are used, featuring written traceability with interpretation decision algorithm, key images, and chart videos. This is crucial for medical legal aspects and team communication. This pyramidal framework draws from international recommendation while offering clear pedagogical structure. Although the pyramid represents a didactic construct, each level corresponds to competencies validated by societies as French Society of Anesthesia and Critical Care, American Society Emergency Physician, American College, and Echocardiography training guidelines. Thank you all.